Maggie, I'm going to go ahead and start from my end.
Okay. Oh, I see the button.
The broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone to today's webinar. I'm Leo Barbarella with Becker's Healthcare, and I will be moderating today's webinar. We will begin the webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you've used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. John Halamka is Chief Information Officer of the Beth Israel Deaconess Medical Center, the Chief Information Officer and Dean for Technology at Harvard Medical School, Chairman of the New England Health Electronic Data Interchange Network, CEO of MA Share, the Regional Health Information Organization, Chair of the U.S. Healthcare Information Technology Standards Panel, and a practicing emergency physician. As Chief Information Officer at Beth Israel Deaconess, he is responsible for all clinical, financial, administrative, and academic information technology, serving 3,000 doctors, 12,000 employees, and 1 million patients. As Chief Information Officer and Dean for Technology at Harvard Medical School, he oversees all educational, research, and administrative computing for 18,000 faculty and 3,000 students. He also runs a blog at geekdoctor.blogspot.com. We also have Nicolas Schmidt. He leads enterprise health products at Nokia Technologies. He's focused on building innovations that help clinicians, employers, and researchers leverage the power of connected health devices. Nicolas is also co-chair of the Mobile Health Applications Working Group from the Consumer Technology Association. Prior to joining Nokia, he co-founded Smart Consult, a medical data analytics company assisting physicians with the longitudinal follow-up of their patients with neurological disorders. Nicolas holds a master's degree in computer science from École Centrale Paris and an MBA from ESSEC Business School. Dr. Halamka, I'll now turn the floor over to you to begin today's presentation.
Well, thanks so much. And I recently returned from HIMSS, 45,000 of my closest friends. I'm sure many of you were at HIMSS. And what you heard was physicians are overwhelmed. There's too much data. There's lots of noise. There's pressures to control costs. So in the face of all of that, how is it we're supposed to deal with patient-generated data, another source of potential distraction to physicians? Well, the answer is we have to do it thoughtfully, and there's an urgency to do so. So let's go to the next slide. We know that the United States healthcare system spends nearly 18% of its GDP on healthcare, and it's only going to get worse. We're an aging society like so many countries in the world. More people are living longer, needing more care, and yet there are fewer people paying into the system. It's not sustainable. I'm 55. I have to manage the health care of my mother, who's nearly 80, my wife, who's also 55, and my daughter, who's 25. I don't really have the tools to understand their progression of disease, their care plan, what they may be feeling today. I need better tools than patient portals, because I can tell you, having 5 different logins and 5 different portals is just not so helpful. As I mentioned at the beginning, just giving data to doctors, here's 10,000 normal blood pressure measurements, is not possible. They have 12 minutes to see the patient, be compassionate, make eye contact, achieve meaningful use, and all their quality metrics. We have to be very thoughtful about how we generate novel sources of data and share them. We know as a country we're getting better. We have increasing innovations, the FIRE Argonaut project, work that's being done at a national level through 21st Century Cures and the TEFCA guidelines to help us exchange data more fluidly than we have in the past, but we still have a ways to go. So we also have to think carefully about if we are going to generate data in patient homes, devices, how do we get that data into our EHRs so we can analyze it? And finally, we know in the United States, the doctors are apprentices. They've been trained by their chief resident 20 or 30 years ago. Quality varies highly. It may be that you have the latest technology in one city and a technology 20 years old in another city. We need to, as a country, do better to offer better tools and up-to-date technologies to all providers, urban and rural, rich and poor. Work to do. Next slide. Now we know we spent $31 billion moving doctors from paper to digital. Now, as I said, we've kind of lost the hearts and minds of nurses and doctors along the way, and the patients aren't totally happy because doctors spend more time on their keyboard than examining the patient. But at least it gave us a floor. We actually now have digitized records, and 90% of doctors are running digital offices. That wasn't possible a decade ago. So it gives us some very interesting opportunity for innovation. But as I keep saying, we have to be careful. If 50% of clinicians already want to quit because they're tired of the administrative burden of electronic health records, adding novel data sources really has to have great value. And ideally, those novel data sources would only be alerts and reminders, things that need attention. Or the data sources would be given to mid-levels, nurse practitioners, clerks, extenders of some kind. I have a patient portal. I'm sure all of you have patient portal or multiple patient portals. And you can find your serum sodium. It's 139. Woohoo! It's not actionable. As you'll hear in a moment, my wife and I and my family members all have medical conditions for which getting something more valuable, like telemetry about our diseases and our progress of disease, would be far better than a patient portal. Now, in the past, we had meaningful use in the HITECH Act, ICD-10, HIPAA Omnibus Rule, Affordable Care Act, and that in some ways co-opted the innovation agenda. Now, I think good news is that we're done with a lot of those projects, so we're going to start to see an explosion of innovation in the private sector again, as we move to different payment models, value-based purchasing, and there's less direct regulation that's highly prescriptive. So we may see an urgency, a mandate almost, to get novel healthcare data sources if we're going to survive these new approaches to risk contracting. We may even have the attention span to do it. Next slide. What did I see at HIMSS? Again, 45,000 people, 2 miles of exhibits, overwhelming. But what I saw as themes, the cloud and cloud-based services, the notion of third-party innovative applications layering on top of electronic health records, linked into the electronic health record with FHIR and other API-type technologies. We won't rely on just the Epics and Cerners and Meditechs and Athenas and eClinicalWorks to innovate. The third parties that are creating novel device interfaces or novel cloud-hosted decision support will connect into the EHR workflow quite seamlessly, cheaply, easily. That's many, many companies at HIMSS strategic plan. Now, of course, there are problems. I've been working in South Africa on the issue of how do I match patients that show up across disparate geographies, who may be working in Zimbabwe or Botswana or Lesotho and come seasonally to South Africa. And matching patients is still hard. I'm working on novel approaches of using biometrics and devices to help identify who a patient is. There are issues in the United States where we have different policies. 50 states means 50 different privacy policies for the sharing of data. It can be quite tricky. I have seen an increasing adoption of Internet of Things devices, recognizing that there is valuable telemetry in many chronic diseases. I'll talk about 3 examples in a moment. But issues like congestive heart failure, COPD, diabetes, and these are reasons we do need data from you in your home, and not just every 6 weeks when you visit the doctor. And as I've said, we are changing our model to pay for quality and pay for outcomes, not just pay for more services. And in that realm, we're going to need to manage the wellness of a patient instead of simply react to their sickness. And I really do believe the time is right, the urgency is clear, and the technology is finally available. Next slide. So let's talk about 3 case examples that illustrate why we need to do this. So my wife, about 6 months ago, says to me, you know, I've had a weight loss I didn't expect, 20 pounds in 2 months. My heart rate seems like it's chronically elevated. And you know, it would be actually useful to understand how my heart rate has varied, because it feels like my heart is just beating quite fast. And oh, my hair is very brittle, and my eyebrow hair is thinning. So what I've just described are the symptoms of thyroid disease. So my wife picks up her iPhone, she texts via a secure texting app her primary care physician, says, I have these signs and symptoms, and you know, I don't have data, though I probably should, but I think it's probably a thyroid issue. Primary care physician then says, I think you're probably right. You need some laboratory data. Let's order a TSH, T3, T4 at the lab 5 minutes from your home. No need to drive to Boston. My wife gets her lab results on her phone an hour after the blood is drawn. She has hyperthyroid disease. Her primary care physician refers her to a specialist. Specialist examines her, makes sure it's not cancer or other bad things, orders some additional tests, concludes it's Graves' disease, tells my wife, you need a medication, electronically prescribes that medication to the Walgreens 25 feet from our house. My wife picks it up, takes it for 2 weeks, and she's fine. So think about what I just said. It's the phone and texting and telemetry. It's connecting labs and pharmacies and PCPs and specialists with patients and families without having to drive or wait. The cycle time to do all this, 48, 72 hours. The end result, cure with low cost, very high quality, high value care. Exactly the sort of thing we need in a value-based purchasing world. It's probably the kind of care all of us would want, as opposed to usual care. Wait 6 weeks for an appointment, get lab tests, wait another 6 weeks, etc. Well, here's a case example actually of using the Internet of Things for my personal diagnosis. As many folks know, I'm a vegan. I have a body mass index of 21. I eat nothing but rocks and sticks, and I'm totally healthy. Imagine my shock when I used a Bluetooth low energy blood pressure cuff and found my blood pressure was 170 over 100. How could this be? So what did I do? I took serial blood pressure measurements. I made sure the data was in fact reasonable and accurate. I forwarded the data to my primary care physician using an app that we've deployed to our patients at Beth Israel Deaconess. And my doctor said, let's look at this data in a structured fashion. Let's look at before and after your commute, before and after meetings with your boss, before and after cups of green tea. Let's make sure it's not a symptom of medical issues or stress or something you're eating or drinking. And we did that. Cycle time, 24 hours. End result, no correlation between activities of daily living, eating and drinking, or stress with my high blood pressure. So then my doctor says, oh, okay, we'll do some lab tests, make sure it's not a kidney issue or some issue with your adrenals. And then we'll put you on a medication. We're going to start you on some beta blockers because, you had an arrhythmia in the past. And this will be good for you. So my doctor starts me on 50 milligrams of metoprolol. I use my Bluetooth low energy monitoring devices. I see that my blood pressure is quite controlled. My pulse goes down to 40, by the way, a little low. But I feel horrible. It's like having 2 negative espressos every day. Beta blockers aren't fun. So then I tell my doctor, let's titer this medication. We'll look at blood pressure and pulse. We'll look at mood. We'll look at energy. We'll monitor this in my home using my phone and these various devices. And we'll try to figure out over a course of a few days the right dose that gives me good blood pressure control, but also a good quality of life. We went to 25 milligrams, then 12.5 milligrams. So today I'm on 12.5 milligrams with a blood pressure of 110 over 70, pulse of 50, and a completely fine outlook on life. And all of that was only possible because I was able, with rapid cycle times, to use monitors in my home to gather data and transmit that information to my clinician in a very specific way. Again, it wasn't flooding the physician with too much data. It was for a specific use case, titering medication effect. Well, we also know that once you start gathering data, you'll have the benefit of big data. You'll understand patients and patients like you. And maybe you can understand a bit more without in any way compromising privacy, because we're not going to care about who an individual patient is. But what will be the experience of my treatment of disease given other patients like me? Such rich data is now available in cloud-hosted systems that provide the kind of telemetry I've been talking about. But my wife, she was diagnosed with breast cancer in December of 2011, and I was able to leverage a lot of data that had been gathered about breast cancer patients like her to help tailor her treatment. Now, obviously, we are going to, in any way, shape, and form we can, protect privacy and security of all this novel data that we're gathering and use it for the benefit of patient care, and never, ever use it to compromise the integrity of the data or the security and privacy of the individual. I tell you all these things because I think we are now entering an era where we have the devices in our homes, we have the mechanism of getting the data onto our phones, and the mechanism of going from phones to the medical record for closing cycle times, improving quality, and reducing cost. Let's go to the next slide. These are just some examples of some of the mobile applications Beth Israel Deaconess has deployed that incorporate novel data sources. We give patients iPhone-based apps to gather Internet of Things information. We gather information from our doctors. We share information with families about telemetry that's gathered about their loved ones with appropriate consent from those loved ones. Again, all under the patient control, all very much geared to protecting privacy preferences. We have a curated app store that now is both iOS and Android that has about a dozen apps in it for doctors and for patients that are leveraging all these technologies. We self-developed a lot of these, but I can imagine going forward, we will leverage commercial apps and startup apps in our curated app store. Once we view it as appropriate, secure, good enough, we'll then make it available in this not Apple App Store environment, but a curated hospital-specific app store. Next slide. We're proudest of probably the application that you're going to see next. If you could just advance the slide, called BIDMC at Home. And what is BIDMC at Home? Well, as I mentioned, portals are not that helpful because they're not actionable. But what if I take the meaningful use common data set, which every electronic health record in America can produce, problems and meds and allergies and labs and notes and care plans and care team, and show you not just your serum sodium, but what is your care plan for today? Oh, you should be taking your Lasix, your Lopressor, your allopurinol, your albuterol. Did you or not? And then I have not only your care plan and your progress on your care plan as a novel data source, but I can take the data from your Internet of Things devices, blood pressure cuffs, pulse ox, bathroom scale, glucometers, FEV1. All of these new devices and telemetry sources go into your phone. So now I have this combination of here's what you should do, here's what you did do, and here's the objective measure of effect. Next slide. And once I have that, then I can do things like ask you, oh, you didn't take your Lasix today. Your bathroom scale tells me you gained 10 pounds. It looks like you've been eating lots of salty snacks. Are you feeling short of breath? Because congestive heart failure patients without diuretics and too much sodium are going to gain water. Weight gain is a good proxy for water weight gain. And symptom scores, oh, I've got 8 out of 10 shortness of breath, enables us to then say, patient, you're now decompensating. Call this number. A nurse is coming to your home. We're going to double your Lasix, take away your salty snacks, and we're going to keep you out of the emergency department. So deploying something like this, we've been able to reduce our congestive heart failure readmissions by 15%. And remember, we're now actually not reimbursed, we're penalized for those 30-day readmissions. And so this kind of tool pays for itself extraordinarily rapidly because it's wellness in your home based on devices in your home and not more emergency department visits. Next slide. We show the patients these graphs that show here's what you did and here's your symptoms and here's a correlation that we're going to call insights between your behavior, Internet of Things measures, and symptoms. And that gives the patient an understanding, oh, you mean when I don't take my medicine, I feel horrible, and then I end up with these really hard breathing issues or whatever. And we give the patients the real-time, secure messaging necessary for their care team. And remember, we're not creating burden for doctors here. It's how do I reach my nurse practitioner or my pharmacist or my social worker, and we ensure that there's this sense of team coordinating your entire care program, and it's very fluidly accessed through a simple mobile app. Next slide. And so I want to make sure that you understand something that has happened over the last 2 or 3 years. This is sea change. You know, maybe it was a decade ago, I said, oh, wouldn't it be cool if we could interface telemetry from the home with a phone? And it was impossible. And there was the Continua Alliance and a variety of standards activities to try to figure out how you would take USB cables and IEEE standards and connect data from telemetry to a computer or something like that. Today, with the advent of very straightforward industry standard Bluetooth low energy interfaces and apps, the data from the scale, the pulse ox, the blood pressure cuff, and sleep apnea monitors, other novel devices, is just there. It's just on the phone. It's just in a container. I don't even have to write a single interface. All I have to do is ask the patient for permission to access the data already on their phone. So this means I can write an app. I can create a service that gets this telemetry or the interpretation of this data to the right caregiver or care team in a trivial fashion. How wonderful it is to take this incredibly complicated problem of device interfacing and have it just simply solved. Truly not anything I need to pay attention to. Now there is, of course, the importance of provenance, because we understand that there is a lot of consumer grade devices out there, fitness monitors and these sorts of things that may not offer the most accurate heart rate or other information. So what we can send to the clinician or the care team is, here is the data, here is the change, here is the provenance. And then they say, oh, well, we know that device is highly accurate and we trust it, or we know that device is, you know, it's something was built into Nike sneakers and it's not a really great measure of heart rate or anything like that. The next slide. So if we look at where 2018 to 2019 is going to go, I want to just look at the Gartner hype curve, because we know that we go from the plateau of inflated expectations to the trough of disillusionment to the slope of enlightenment with any new technology that is introduced. Internet of Things, biometrics, Bluetooth low energy, all these technologies are really now coming into their own. They're real, they're effective, they're reliable, and they actually don't require me to hire support people. They are, I can tell you, having deployed all these to our congestive heart failure and other population patients, they're not creating a burden for IT. They're not creating a burden for doctors or nurses. Now, as you can see from this slide, there are still a lot of highly speculative technologies out there. How many times have you heard the pitch, oh, I've got a blockchain-enabled machine learning cloud-hosted API? Yeah, be careful. But I can tell you, Internet of Things and the technologies we've talked about in this webinar have gone beyond the hype phase, and they are truly at the plateau of productivity and implementation. So that's my story. We need to do it. The technologies are mature, and the time is right, given the alignment of economic incentives and a little bit of slowing we're seeing in the regulatory burden. So I'd like to turn it over to Nicolas Schmidt to tell us a bit about what Nokia is doing in this regard. Nicolas, take it away.
Thank you very much, John. Very interesting to learn about all these new innovative programs you guys are doing at Beth Israel, and I'm glad your blood pressure is going a bit better. So today I'm not going to talk about blockchain, cloud-enabled machine learning systems, but what I hope to share with the audience is really what we have learned over the last 5 years, working with health systems, helping them implement connected devices like what you have described in your work at Beth Israel. And so just to give the audience a bit of background on why Nokia is presenting here today. So we started as a company named Withings in the consumer electronics field. It was back in 2009, and we were actually the first company to create a Wi-Fi connected scale. And from there, we built many more devices and got acquired by Nokia in 2016. But really, when we started for our distribution, we were really relying and trying to get directly to consumer, mainly to retail stores. And maybe 5 years ago, the medical world started to come to us, and we had clinicians telling us, okay, I want my patient to use this data. I want to access the data from your devices because they look great, they are easy to use, they are not that expensive. And so I really want to give you some insights in the next few slides on how you can integrate consumer devices and the data they generate into your programs. So in the US right now, more than 80% of healthcare costs are related to chronic disease, and chronic disease actually accounts for more than 75% of death. And fundamentally, patient-generated health data give us the opportunity to transform the way we deliver care. So moving from a mode that's really episodic and reactive to something that's much more continuous and preventive. And we all know that it is much, much better suited for chronic disease management. And so we like to think you need 3 components to do this. First, getting the right data. Then being notified of changes in trends at the right time, which enables you to take the right action. So the main way Nokia helps hospitals partners is through our ecosystem of connected devices. And I'm really saying an ecosystem of devices. We didn't want to create just one device and one single dimension. We really wanted to help users build a comprehensive picture of their health, understand the relationship between their different metrics. And so what you see on top of the scale is our range of connected scale that measures your weight and your body composition. As I mentioned at the beginning, that's the first device we started with. After that, we developed the wireless connected blood pressure cuff, a thermometer. The watches that you see on the screen are actually our activity and sleep tracker. So they are as smart as any other wearable on the market, but they look like nice, simple to use analog watches. And the pad that is at the bottom of the slide is our new sleep tracker that we're going to release in the next few weeks. So it goes underneath your mattress, senses different parameters, and measures your different sleep patterns. And so by that way, by having this ecosystem of devices, the patient can see how his sleep, for instance, is going to affect his blood pressure in the morning. And so by getting the right data, clinicians stop being blind between office visits. We can somehow help fill the gap between this consultation, understand how patients are doing, and be able to act proactively. And as we all know, part of the medicine from chronic disease lies in lifestyle changes. So being able to have some understanding of metrics like activity level, sleep patterns, can really help clinicians in better assist their patients. That being said, not all devices are created equal. And getting people engaged with health technology is very challenging. Individuals rarely care about their own health before it's too late. And certainly we don't want to be patronized, by a piece of technology telling us what we should eat or when we should go exercise. So what I want to share in the next few slides is basically 3 lessons that we have learned about why design matters so much in making people engage in the long term with their devices, in creating lasting behavior change. So first of all, it needs to be painless. When we were doing our user research before creating our activity tracker, we found that the two main pain points with wearables are one, design. People feel wearables are bulky, it's not easy to use, it's sort of a rubber band on your waist. And two, that charging is really a pain. Nobody wants to have to charge a device every day. We do it for our smartphone because our smartphone provides so much value to us, but we don't want to do it for other types of devices. And so as you can see on this picture on the screen, our activity looks like a real analog watch. It's something people have been used to wearing for decades. There is no button actually on it, and the battery life lasts up to 8 months. And so my point is that many connected health companies try to create brand new objects or brand new product categories. And creating new objects that don't already exist in people's lives and require them to adopt a new routine, first makes initial adoption very difficult, but most importantly makes long-term engagement and use of the device very, very difficult to achieve. And so when we think about it, right, very, very few objects have made it into our everyday life over the last decade. The smartphone is one, but there aren't that many others. So it's much more efficient from a product perspective to take an existing object, something people already know, use, wear, and augment it by adding connectivity to a smartphone, by adding an activity sensor, by adding a heart rate sensor. That way you create a device that's really painless to use, that fits into existing routines. And so that's what we try to achieve with our activity watch, generating like much higher long-term engagement than other types of wearables. The second lesson is that these devices need to be beautiful. And we are a French company, so as you can guess, this matters quite a lot to us. But I would argue that it also matters enormously in the digital health space. And so, for example, when we visit a friend's house, we see a lot of devices in the living room, but we never see any health-related devices like a blood pressure monitor. And that's because most blood pressure monitors look overly medical and generate anxiety. So that's why we wanted to make one that, just look great, that people were not going to hide. And of course, if your device is available in plain sight on your living room table, you're most likely to use it. But I think more importantly, it helps create a positive statement that we are trying to keep our family well, that we are concerned with our family health, family wellness. So something contributing to our health does not have to look ugly and medical. And last, it needs to work for the least tech-savvy users. Senior citizens in the US account for more than 1/3 of the total US healthcare spending. So that's why we need to develop products that are ageless. And what takes most of our energy when we design our connected devices at Nokia is working on making most of the technology disappear. And so when you do some research study around sleep and sleep tracking, a lot of people will tell you, well, I don't want to wear something while I'm sleeping, and I don't want to have to press a button to start recording my sleep. And so that's why we came up with this form factor of a pad that you put underneath your mattress. You install it once, and then it's there. It senses your heart rate, breathing rate through your mattress, transmits automatically the data. You have no button to press, nothing to do. So it's really about making this technology invisible and making it disappear. Okay, so now you better understand how your patient can get excited or at least engaged in using connected devices. So the next step is really about accessing this data and making sense of it. And on this part, we've seen our hospitals partners use really two different methods. So on the one hand, some want to bring this data directly into their existing electronic health record environment. And so Nokia has done the work with some of the major EHR vendors so that the data from our devices can flow directly into the EHR. So as an example, if you are an Epic customer, then as part of your MyChart package, you have some interfaces that have already been developed. As John mentioned, there is no code to write in this case with this modern technology. These interfaces are free, and once you activate them and get patient consent, then the data from, say, their blood pressure monitor will flow directly into their blood pressure flow sheet in their health record. And so these hospitals partners have built some rules on top of this flow sheet and created some UI to access the data. On the other hand, we have seen some partners who think that the EHR is really a static record, that it's not well suited for any real-time continuous monitoring. And so what they end up choosing is something that John mentioned a bit earlier. It's basically these apps or add-ons that are sitting on top of the EHR, like our Nokia patient care platform that you can see on the screen, and that integrate into the EHR environment very well, but will complement the health record for the remote monitoring program. In any case, whatever solution you choose, you want to make sure that you can provide some user interface where clinicians can see very quickly what are the trends in all of this data. Two, some form of stratification. It's so much data that you want to know straight away who are the few patients who are going to need your attention today. Three, some analytics. As John mentioned in his very first slide, all caregivers right now, all clinicians are really overwhelmed. So you want to make sure you have the analytics capability and you can make all of this data actionable. And last as well, some good aggregated reporting. Most of these programs are new for health system, so you really want to know what's the most effective so that when you scale your program, you can learn on these best practices. So up until last year, there was no direct way to get reimbursed for remote patient monitoring only. But in November, CMS has made some updates to the Medicare physician fee schedule around remote patient monitoring. And so the first thing that they did is that they created a clear difference between telehealth and live visits and remote patient monitoring, which is much more about collecting and analyzing data than any live interaction with patients. And so the big news was that CMS unbundled the CPT code 99091. So this code doesn't depend anymore on creating a coordinated comprehensive care plan or providing chronic care management. For those of you who might not know the CPT code 99091, basically you can get reimbursed for spending 30 minutes a month analyzing a patient's remotely collected data. The American Medical Association has also been working and creating more codes around remote patient monitoring, and we'll see if these codes get coverage next year. But Medicare seems quite interested to do more in this space, and I think at the very least it's fair to say it's improving quite fast. It's improving quite a lot, and now there are ways to get paid for remote patient monitoring. So the next question is usually, how do you get these slides? What are the best workflows? And so one area that has been gaining significant traction among Nokia health system partners is this concept of a tech bar. It was pioneered a few years ago at Ochsner Health System in Louisiana. And the idea is quite simple. Basically, during their office visits, some patients get prescribed a Nokia or some other partners' connected devices. And so right after their visit, they can go to a location inside the hospital, which is this tech bar, a sort of retail location, where they can buy their device and they can also get some help to set it up. So download the app, find out their iCloud password if they forgot about it, create their account, do the Bluetooth pairing, so that when they get on, basically everything is set up and they just have to use their device. And so at Ochsner, 90% of patients who get this sort of digital health subscription or connected device subscription end up going to this tech bar just after their visit. And for those of you who might not have the space or the bandwidth now to do these programs, partners like Nokia can also create just an online storefront for you where at least you're making the delivery to patients much easier. Okay, so this is my last slide, and this is about staffing for remote monitoring. And of course, it's not a doctor who is going to look first at all of this data. And what we have seen with the programs that are deployed by our partners, that it can be quite flexible, and pretty much anyone in the care team can be involved. So some programs will ask nurses to review this data. Some others will have care coordinators, and it tends to work a bit better in that setting. But we also seen some pharmacies getting involved, some health coaches getting involved. So I think the good news is really to realize that you can use your existing staff. You don't have to hire a whole new team. And maybe the last thing I want to add is that among the most advanced programs that are out there, health systems tend to put a collaborative practice agreement in place. And so really getting to a point where a primary care provider can delegate part of the care to this remote monitoring team. So for instance, I'm thinking of a pharmacist who can do a drug titration remotely in certain chronic disease like hypertension. So thank you all very much for listening to me. I hope this gives you some insights and some interesting lessons as to what has been going on and what we have seen. And so I'll now turn it back to the team at Becker for our Q&A session.
Thank you, Dr. Halamka and Nicolas, for the fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. Our first question is, Dr. Halamka started his presentation mentioning numerous patient portals, understandable since each provider/network has their own EMR. Does he foresee a time when the software will truly catch up with the patient-centered focus and the patient will have their record and allow the providers access to it?
What a brilliant question. So for those who attended HIMSS, you know that Seema Verma announced that really that's the intent. As we look at the end of the meaningful use era, which is very much provider-centric, provider data exchange, portals, where patients were almost tangential to the care process, will be replaced by patient-centered data exchange via APIs. And how is that going to happen? She also announced the Blue Button 2.0 initiative. Now, for those of you who remember Blue Button 1.0, that was really making claims data available via text file, wasn't really that helpful. Blue Button 2.0 is saying Medicare will have a FHIR API on the entire Medicare data set with an OAuth access layer so that patients on their phones can access all their Medicare data about their visits and their claims and explanation of benefits all on their phone seamlessly. Apple has introduced in iOS 11.3 a FHIR native interface that out of the box connects to Cerner, Epic, and Athena. And as you exit a visit, all the data about that visit, including problems and meds and allergies and labs and notes and care plans and care team, just appears on your phone, native to iOS. And certainly we're seeing multiple app developers creating these new ecosystems for patients to manage and exchange their own data. And the exciting part is, as you say, instead of saying, I have a provider recording an episode, we have patients with a continuous healthcare record on their mobile device, and then granular control over how they share it. Maybe it's with other family members. Maybe it's for clinical trials or clinical research. Maybe it's a sharing among providers. Now, I'm realistic, and I know that my mom, who's nearly 80, isn't necessarily going to want to be the person who curates all her own data herself on her mobile device. But you know, she's very happy to delegate that to me. And so I actually already, through some work that we've done at Beth Israel Deaconess, curate my wife's data on my mobile device. So it will be an ecosystem of cloud and APIs, of apps that enable this, and not only patients doing it, but patient-specific delegates doing this.
Great. Thank you for clarifying that, Dr. Halamka. Our next question is, has Nokia looked into this type of patient data tracking for post-surgical patients and their outcomes?
Sure. So yeah, I can name a few areas when we have seen there. I think John gave a great example on the congestive heart failure remote monitoring part, and that's definitely an area where there is a lot of traction and lots of interest with the 30-day, 90 days readmission penalties. Another area I'm thinking about in pre-op and post-op is around bariatric surgery. And so, again, being able to better understand how our patient is doing from a weight perspective, a nutrition perspective, after the surgery is also something where we've seen quite a few partners try to develop program and be quite successful. So that's like the two main areas that would come to my mind.
Great, thank you for that answer. Our next question is...
If I could just add a quick comment to that. So we're seeing more and more need for patient report of outcomes. And so I can imagine in the post-op case, you know that a patient might be asked questions like, how is your wound healing? And instead of having to come in for a follow-up visit, they take a photograph and using a secure app, transfer the photograph of their wound and some telemetry or data about their activities of daily living back to their doctors. Think of how much convenience patients and families would have and how much free time doctors would have if instead of just routine post-op care, we did this in the home with new tools. And I see that happening soon.
Thank you, Dr. Halamka and Nicolas, for clarifying that. Our next question is, what all qualifies as objective PGHD for the billing code stated? Wearables, other objective data?
Well, I can take a first stab at it. So this code is really an old code that was unbundled. So it was created at a time where most of the technologies we have presented here didn't really exist. So as it is today, I think what most people understand is that pretty much any patient-reported data is eligible. So it can come from a wearable, a connected device. It can also be just more, as John mentioned a bit earlier, kind of surveys or even images that could be transmitted. So the general understanding, at least in my opinion, is that any type of data would be eligible as long as it's collected by a patient or by one of his caregivers.
Great. Thank you so much.
And I know we've been talking about CPT here, and that's good. That's fine. But remember that I live in a world where 80% of my reimbursement is value-based purchasing, risk contracts, pay for quality and wellness. So in some funny ways, I actually don't need to send a bill. What I actually need to do is reduce the total medical expense by using patient-generated healthcare data to keep people healthy in their homes. Because keeping them healthy in their homes in a value-based purchasing world is its own reward.
Great. So what does patient engagement look like? How long are patients using app versus Bluetooth-enabled wearables?
Well, maybe I can start on that, and John, I'm sure you have some good insights from all of the programs you guys have been doing at Beth Israel. So I wouldn't necessarily make a distinction, between apps and devices, because I think some of these devices are actually completely invisible, right? That's what I showed in some slides. So they don't require any effort, and as long as they are there, like your sleep tracker, your bathroom scale, you'll get the data. And like as long as you're used to weighing yourself in the morning in the bathroom, well, now your scale is connected and the data is going through. So we're not trying to create a new routine, forcing people to adopt new habits, but we're just really enhancing and connecting and better sensing things they're already doing in their daily life. So one thing we see typically in a remote hypertension management program is that patients are usually asked, to take a blood pressure measurement at least once a week, and the average is usually around 4 to 5 measurements a week. So really strong engagement that lasts for quite long time, because you know that this data is useful for your care team. You also know that someone is looking at this data. So really engagement in this type of program tends to be really, really high, as long as the device or the app that you are using isn't too cumbersome and doesn't require you to create new habits or have to report data 5 times a day. As long as you select the technology right, and you make sure that patients understand that there is someone behind the dashboard looking at the data and that it is useful, we really see very, very high engagement.
So what is patient-family engagement? Again, a fabulous question. So what I believe the future requires is that there is a care team, care navigators, care traffic controllers that work with patients and families to get them the right care in the right setting at the right time. And, numerous examples from my own family, which is when my father-in-law had a stroke 5 years ago, my wife didn't know what care he needed, where he should go, how he should be urgently evaluated. And so as we think of this distinction between providers and patients and families becoming not separate silos, but one care team working together, it's this combination of subjective and objective data, of machine learning and cloud-hosted services, of apps and APIs that's going to make that possible. I really look forward to an era where suddenly, instead of thinking of waiting 6 weeks for an appointment or waiting for a callback, we have all much more real-time control of the healthcare of our patients and families. And I know I'm sounding a little bit like the Gartner hype curve, but I've got 12 machine learning applications running in production today. Once you have the data and can curate that data and teach machine learning algorithms, you can start creating chatbots and much more effective means of tying together our very heterogeneous and disconnected healthcare system in a patient-centric way.
We've received a ton of great questions, and the next one is, can you incorporate the data outputs into an alert system and/or care plan?
So, John, do you want me to start?
Oh, sure, go ahead, and then I'll continue, because this is an exciting question that involves, in fact, FDA regulatory risk as well. Sure.
Yeah, it's a very good one. Basically, in terms of alerts, what we have seen is that now it's easy, it's free, you don't need any development to get this data into an EHR database and EHR flow sheet. And so from there, you can build any types of alerts that you want, standard alerts on your flow sheet. As John mentioned, we see more and more our system actually trying to use third-party apps that sit on top of the EMR and that might be better suited to do this type of analytics, right? Sometimes it's continuous data, it's a lot of data. It's not necessarily about finding a red flag in the data, but more about analyzing trends. And so in that case, using Fire APIs or maybe some less recent technology, but kind of similar, you can add these modules in your EHR that we look at this data and create some alerts, relate them to any changes that could be needed in care plans.
And so the FDA, Bill Maisel and others produced a risk-based approach to what algorithms might be regulated. So imagine that your Internet of Things information shows that you're gaining too much weight and you should, eat less, exercise more. If an app tells you to do that, no problem. It's not really a risk to you whether it's right or wrong, and it won't be regulated. If it says, it's really time for you to come in for an appointment, that's more of an administrative function. It's not going to be regulated. If it does active diagnosis and treatment, that's going to be regulated. And so what we tend to do is focus a lot on wellness and administrative type apps, and we build rules that help humans then activate care plans and doctors get involved, and we avoid having the machine, so to speak, decide that you need a treatment and just automatically recommend a dose of a medication be changed. So we write rules, and those rules are based on subjective and objective observations, but humans are very often involved to interpret them and to ensure you're getting the appropriate care. So it'll be an adventure because, as we talked about, we don't want to burden the care team with unnecessary data, but we also don't want to miss sentinel events. And maybe someday, if you aren't using the Internet of Things to monitor a patient, it could be malpractice. We'll see.
Thank you, Nicolas and Dr. Halamka, for those great answers. Unfortunately, it looks like we only have time for one more question. So, how will the interoperability of laboratory data, i.e. glucose pregnancy tests, be implemented in a way to be compliant with CLIA regulations? Are there any data from a medical legal perspective that won't be trusted from patients, devices, etc., that physicians will still want to deploy their own monitoring methods?
Well, hey, Nicolas, you have any comments on CLIA?
I think you can go ahead.
Okay, so what I've seen is that CLIA was developed in an era when there were really concerns about charlatans. People creating phony instruments that inaccurately report results and cause harm. At the time, I would say medicine was a bit more patriarchal. We need to do this in a very official way, and the doctor needs to be involved, and the patient can't be trusted. What I've seen over the last 5 years or so is a lot of the patriarchal aspects of CLIA have dissolved, right? Patients can get access to their data immediately. APIs are being built so patients receive the data at the same time the doctor receives the data. I mean, there's again this sense of collegiality and working together. So what does that mean? Well, sure, there's going to be FDA approvals on medical devices that do diagnostics, but I think increasingly we're going to see bedside testing and at-home testing, and as long as there's provenance that says this is a data element and it came from an FDA-regulated device, who cares if it's sitting at Quest or LabCorp or in the home, as long as it has the provenance, and that provenance implies trust. We'll see less and less patriarchal, top-down, doctor-driven care.
Well, that's all the time that we have for today. I want to thank Dr. Halamka and Nicolas for their excellent presentation, and Nokia for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.
Thank you, everyone.